think about what can we do to make today a little better, whether that's having child life or art therapy come by and offer some activities for them in the hospital, or adding a resource or support to the home that makes life a little better for the parents, some respite care so that they can actually get out and go shopping or have a date night or something like that. And for us to provide the best possible care, and for families to feel that they're able to provide the best possible care, which is different from everything, right? Everything that we could possibly do intervention-wise is typically not the best possible care, but I think when parents say they want everything, that's what they're really asking for. They're saying, help us figure out what the best possible care for our child is. So I often try to rephrase that so that we can use that idea of what's the best possible care, and it might not be reintubation in this scenario, or it might not be coming back to the hospital, but you sometimes have to get over everything, or ask a family, what do you mean by everything? What does everything mean to you? For some of them it really does mean everything that medically can be done, and for others it means we want to make sure that we feel like we gave our child every opportunity and we're the best parents we could be. So support can be initiated early and integrated with disease-modifying treatment, and so this is just an example of that. Previous diagrams would basically be like, okay, we're going to do disease-modifying treatment, and then boom, okay, we can't do anything more. We have decided as a medical system, as a hospital-based team, that things are now futile, so we're going to switch over to palliative care, and then we're going to discharge to hospice, and then there'll be bereavement. And what we've realized is that that causes a lot of distress for families, because usually we're not bringing them alongside to see things aren't getting better like we hoped, or we had been anticipating that they might respond to this treatment and they didn't. So sometimes when the family comes to the realization that treatment isn't helping them achieve their intended goals of living longer or having a cure, and when the team comes to that, can be very different times. So this, I think, allows for more discussion of that along the way, and more discussion of what burdens is the treatment imposing on the patient and the family, because that's something that oftentimes gets left unsaid or not emphasized. And there are a lot of trade-offs with the treatments we provide. If we're talking about doing a tracheostomy for a pediatric patient, for that family, that means managing a tracheostomy at home, with oftentimes nursing in their home for hours at a time. And that's a really big trade-off. And so we want to make sure that they understand what that means. And for the child, is it going to help the child to feel more comfortable and to be in the place that they want to be? Then there might be a good argument for it. And then in large multi-center cohort trials, over 2/3 of palliative care referrals were alive 1 year later, which again is very different from how things work in the adult setting, oftentimes because even if they have chronic complex conditions, they have younger, healthier organs overall, and the adult diseases that palliative care often follows are things that progress more rapidly. So we follow these patients a long time. And then this is just showing somebody's health status over time and how complex it can be for a family to figure out what's really going on with their, with what they should hope for. So, the health status may have started off good, and then there's these little bumps in the road, and then maybe we finally get to a point where we make a diagnosis because things start really going down, and we figure out, oh, the weakness that you were seeing, the inability to feed well, once you got home from the hospital, the increased work of breathing your pediatrician noticed when you brought your 1-month-old into the hospital and they were admitted and kind of tuned up and sent home, like, that's, SMA, so spinal muscular atrophy. That might be something that presents with a pattern like this. And then we have to say, do we have an intervention for it? So for SMA, now there are some interventions. So maybe that stabilizes the course, either improves or at least stabilizes it so that they don't have the ongoing decline from the disease that's expected. But maybe in another situation, it's renal failure. And so renal failure is diagnosed, and then maybe hemodialysis is started, and then depending on one thing or another, either it continues and they're able to get back to a health status that may be similar or different to where they started, or maybe for various reasons it doesn't work and there's another trajectory down to death. And with health conditions that have a lot of ups and downs, it can be very hard for anybody to predict which is the one that they're not going to recover from. And many of the families that I follow will tell me, people have told me time after time that my child wasn't going to survive. You know, they weren't going to survive to delivery. They weren't going to survive the newborn period. They weren't going to survive their last hospitalization, and they did, which makes it really hard for them to trust us when we say, we're really worried and we don't know if they're going to survive this particular illness or admission. So that's one of the things I try to listen for. If they have that kind of story, then I need to respect that story. And they oftentimes will describe their child as a fighter and somebody who's really, you know, beat the odds before. And so that's clearly what they're hoping for. So how can I respect that but also say, wow, it sounds like they've beaten the odds a lot of times and that they are really strong. You know, we'll have to wait and see what happens and how this particular fight goes, you know, because we all lose a fight eventually. And I am hoping that they win this fight too. But if they don't, we're here with you and we will figure out how to move forward together. So that's the kind of language that I try to use with families so they know that we're hoping with them for the best possible outcome, but we're also sharing when we're worried and sharing that we will walk the road with them no matter what happens. All right, so some things that I want to emphasize that palliative care is not. It's not closing the door on curative treatment. Now, sometimes hospice in some situations, which is, you know, for the last 6 months of life, sometime if you accept hospice care, then you have to close the door on certain types of curative treatment. For pediatrics, actually, that's typically not the case because of concurrent care, but for palliative care, it shouldn't have to be the case ever. It's not pushing for less aggressive therapy, although it's oftentimes making people understand that less aggressive therapy is available and helping them to understand the benefits and burdens of one type of treatment versus another. It's not only hospice and end-of-life care. It's not meant to take away hope. It can sometimes make people sad to think about something that they haven't wanted to necessarily put in the forefront of their mind. But most families tell us in studies that they would rather know the real information so that they know what they're facing and can make decisions based on the best information possible. So it's not intended to take away hope, but to help people hope for maybe the most realistic or a better fit than what they could hope for before. And it's not giving up. This is one of my pet peeves, right? So when the medical team comes to the family and says, hey, whenever you are ready to quit, we can extubate. Like, what family wants to have their going out feeling be, I quit, you know, I gave up, and so my child died? That is not what we should ever say to families, right? It's changing the goals of the fight. It's changing, you know, how we want end of life to look. So if I want to be able to hold my child and to get in bed with them, then that may be improved if they're compassionately extubated. And if I want them to be comfortable, that may or may not be improved by making those kind of changes. But we should never make the family feel like they gave up. Another way that we can sometimes, you know, take that language in our heads, because sometimes we really are waiting for them to be ready. That's what we're saying as a medical team, is we're saying, you know, we've come to this point where we realize we're at a crossroads. You know, are you there yet? So that's what I think we mean when we say something like, whenever you're ready to quit. But, you know, what we should be saying instead, I think, is, you know, sometimes for families it's helpful to say, you know, Johnny is showing us that his lungs don't work. Every time we've tried to extubate, you know, different problems have come up that are consistent with an ongoing decline in his function. At some point it would be reasonable to sort of allow all of us to follow his lead and to support him through that. So sometimes it's helpful for families if we let it be that they're following the lead of their child, or that they're leaving it up to God, and we're going to do things to focus on comfort and let God, bring the situation to whatever close that he or she sees fit. So again, I don't use the God phrase unless that's what the family is using to me. So I try and reflect their language, which you have to do by listening, right? You listen first, you hear what they're saying, what makes sense to them, and then you reflect it back, maybe with some changes that allow you to give them some more information. All right, spent a long time on that slide. So what is palliative care if it's not those things? So I have here listed some of the tasks of palliative care. And palliative care is not a job that's only done by palliative care clinicians. So palliative care can be done by everybody, and hopefully is done by everybody who's working with a patient with serious illness. So it includes things like communication, so identifying problems and challenges. One of my favorites is when I go talk to a family and they say, well, the PICU doctor said this, but the oncologist said this, and the nephrologist said this, and the nurse said that we're having a good day. And it's like, yes, all of that is true, obviously people didn't talk to each other before they got to the bedside. That's the other problem that we sometimes have. But it can sound very different to families. So making sure that we're communicating as clearly as possible, that we're talking to each other, that we're giving the family the best opportunity to understand that the team is all on the same page. It doesn't mean that we all agree. It doesn't mean that we are locked into a specific treatment plan for the rest of life no matter what, but do we all know what we're thinking together, and are we expressing that clearly? And then helping the family have prognostic awareness that develops over time. And I started prognostic awareness because I was practicing for a year before I heard this term, and then I was like, this is what I do every day. So I help families develop prognostic awareness, which means, how have things changed over time? What does this disease or condition or illness mean for their child's life? And how is it different this year than it was last year? And this takes time for families. For medical teams, it can be fairly quick, like, oh, yep, they go in this bucket for me because they have this specific disorder, so now I know what to do and how I'm going to approach things. But it might be the first time that they've ever had anybody seriously ill in the family. It's likely the first time they've ever encountered this specific problem. So it's going to take them some time to emotionally and cognitively figure out what's going on and how they want to respond to it. And if we don't give them that time, then they're not going to make good decisions because they're not going to really have let it sink in. And this can take time when there's a change in the condition. Suddenly, they come in with a respiratory illness that everybody else in the family has and did fine, but it knocked them flat because they have low muscle tone and can't cough well, and they got congested. So helping families develop prognostic awareness and then figure out what to do with it is one of the tasks of palliative care, and that involves letting them emotionally process things. So one of my team members, we were talking about what's a good day at work not too long ago, and she said, sometimes a good day is when I make somebody cry. And I was like, really? Like, tell me more about that. And she's like, because then they are really feeling what's going on in the situation. And sometimes they need to cry or yell. Anger and sadness are two ways of expressing what you feel when you just are a parent or a family member and you can't make something better for your kid. They are really common expressions. Once they've expressed that emotion, then sometimes they can move on and do the cognitive work that we're asking them to do. But sometimes until they've expressed that emotion, they have a really hard time with the cognitive function that we're asking that's so important. And then we can get to setting goals, doing advanced care planning, and making decisions. Care coordination, so back to coordination with other providers. Sometimes it's really important to get the team in the same room so we can all hear from each other. Like, what are you experiencing when you try and bag the patient? Why is the ventilator constantly going off? You know, are we getting different type of secretions, you know, today than we did 3 days ago? And what does that mean to other people on the team? How can we best work together through that? And community partners. So for a lot of these families, they need community partners as well, so they can get back home if that's something that's important to them. We do a lot of symptom management, both of day-to-day issues, of expected symptoms down the road. So you just started a bone marrow transplant, so you feel great today, but in a few days you might have these type of symptoms, and here's how we'll manage them. And then emergency issues that can come up, especially at home. I find that if we have a plan for those, we get a lot fewer, you know, I had to be in the